Good afternoon, Warrington. Welcome to Grand Round on Friday the 9th of October. We're live from the Education Centre and delighted to have us with you. This is a really special Grand Round. I'm delighted to have with me Dr. Mithun Murthy, Consultant in Respiratory Medicine, for a session that's just so relevant for us all now. COVID-19, a clinical update and a review of the new SOP. So I hope you really find this useful. If you do have to miss any of it at all, remember that the recording link will go out later this afternoon so you can watch it at leisure. So I'll hand over to Mithun. Thank you.
Hi everybody. As Alison said, thank you for the introduction, Alison. I'm Mithun Murthy. I'm one of the chest physicians here, and I'm going to do a clinical update on COVID-19 and a review of the trust-wide SOP for some practical guidance on managing COVID-19 patients as well. As you know, cases have been ramping up, especially here in the Northwest, so this is really quite important right now. All I want to say is that there is a chat box on the team, so if you have any questions, please do type them into the chat box. Alison will be keeping an eye on the chat box, and if there's any sort of very relevant burning questions that are there at that time, I'm happy to answer them as we go along, or otherwise there's some time at the end for questions as well, and I can review all the questions in the chat box and answer them to the best of my ability. So, but yeah, please feel free to type any questions into the chat box. As Alison said, this is being recorded, and we'll send the recording out to everybody so that you can review that as well. So let's make a start. Yes, it works. So the main contents of my presentation are going to be, and again, apologies slightly for it being quite a technical and clinical update, but I think it was quite relevant to make it into a very clinical presentation. So it will have a lot of information, it will have a lot of clinical stuff. So if you are a non-clinicians, so just bear with us. But I think this is really relevant at this point in time for anybody dealing clinically with COVID to know exactly what to do really. So we'll start off with clinical presentation of COVID and what investigations to look for and to request. I'll go on to a little bit of cohorting of patients. So not only do we need to cohort patients based on whether they are COVID positive or negative or suspected, but also a lot of their baseline functional assessment. And this really helped us to manage patients very well in the first wave back in March, April. And if you're seeing patients, if some of you are seeing patients down in ED, it may help to make a judgment on whether the patient should be admitted into hospital or not, and what is the basis for that. Again, I will, as mentioned, concentrate on a lot of the clinical management with emphasis on a lot of medications. There has been a lot of research that has happened during the first wave of COVID. We were very lucky to be part of that research, and one of the biggest trials in COVID in the world, in the form of recovery trial. We are a site for that, and I was principal investigator. I am principal investigator for that. So a lot of this research has led to some very useful results, and therefore we should put that into practice, and that's this section where it emphasizes on medications management of these patients. And then I'll end towards the end of the presentation, again emphasize the importance of escalating these patients, especially with regards to their respiratory needs and ventilation needs, and how to do that in a practical way, and finish off with some signposting and resources. So let's kick off with the presentation. I mean, you've all obviously seen all the updates from the government. The three main criteria, the three main symptoms to look out for are new continuous cough, fever, and loss of sense of taste and smell. But just to delve a bit more into the prevalence of these particular symptoms and the sort of how they may present. Fever can often be quite high and sustained for a number of days, but may well be intermittent as well. And as I said, the fever can be anywhere between 50 and 90%. So the absence of fever doesn't completely rule out COVID. Cough is also fairly prevalent, but the interesting thing is mostly is a dry cough. Sputum production is much less common. And it's quite important to recognize that breathlessness, again, is prevalent, but may come slightly later on. And this very often heralds the development of a pneumonia relating to COVID. So it usually starts off with a flu-like illness, but possibly by day 5 or 6 may develop into a pneumonia. So it's quite important that we recognize that timeline in patients. Especially now in the second wave, there is a lot more community testing happening. So there are patients who might present to hospital who are already diagnosed to have a positive COVID swab in the community. Either they've requested the swab themselves or have had that swab requested by their primary care GPs. So they may already have that COVID status known, and they may already be at day 5 and 6 and then present with those complications of pneumonia. One of the things that we do see, especially in the elderly patients, but across the board really, is this phenomena of what's called a silent hypoxia or happy hypoxia. So patients appear relatively well. They are not working particularly hard for their breathing. But when their oxygen saturations were measured, they were particularly low, and this was seen across the board. So this is really important that you don't get complacent with patients who are diagnosed to have COVID pneumonia. They can go off very quickly, and their escalation needs to be quite rapid. Like I said, they may seem comfortable with low saturations. The loss of sense of smell and taste is a very unique thing, which we've seen. It's not necessarily only related to COVID. There are other viruses which we have seen that happen before, but this seems to be a very interesting phenomena that happens with this particular virus. And it's very common. I think now there has been some research into it that as much as 95% of patients develop some or the other form of this symptom. Less common symptoms of GI upset may well be there, and all the other sort of symptoms which may relate to an upper respiratory tract infection like a runny nose, sore throat, etc. So that's how patients will present. As with most patients, they'll get a battery of initial blood tests, but there's some interesting things to look out for even amongst those. We're almost universally seeing a low lymphocyte count, a lymphopenia, as much as 80% of cases. And although anecdotal, I have personally seen during the first wave as well that it does correlate with how patients deteriorate or improve. And I've seen that time and time again, that an ongoing dip in the lymphocyte count correlates reasonably well with the patient deteriorating, and the patient who's improving, we see their lymphocyte counts recovering. So it's an interesting phenomenon again, and it's something to look out for, and more research needs to be done in that. Other markers like CRP are also interesting, that again may point to maybe bacterial superinfection. D-dimers are an interesting thing. Normally speaking, as a chest physician, I would probably not have liked to advertise D-dimers very much. However, there does seem to be some importance of D-dimers in COVID, because there's enough evidence to suggest that COVID gives some form of a coagulation problem. And makes you more predisposed to clotting issues. So a positive D-dimer should prompt further investigations. And again, a transient rise in transaminases liver function tests are also seen. So just putting these things together in the initial assessment of when you are faced with a patient with suspected COVID, what are the things that would make you make you suspect this high likelihood of a COVID pneumonia and its early complications, and virtually scream out COVID to you is things like this. So high fevers with the loss of sense of smell and taste, lymphopenia, and bilateral fluffy changes on chest X-ray, or even a full 4-quadrant change on chest X-ray. That should really be ringing the alarm bells that this is highly suspicious COVID pneumonia. There isn't any bespoke severity tools really for COVID as such, but the traditional tools of how we assess severity in a patient are just as valid. So using a NEWS2 score as you would with any other sick patient, or using a Curve 65 score for any other pneumonia is still just as valid. And you should consider additional investigations, especially microbiology investigations, if you have a severe pneumonia, as you would with other severe pneumonia. So things like looking for urine Legionella pneumococcal testing or blood cultures. I cannot stress the importance enough of this hypoxia issue. Like I said, they may look all right, And so therefore doing a blood gas if there is any hint of low oxygen saturations is really, really important. And as mentioned, if you suspect a VT, especially if it's a positive D-dimer, have a low threshold for requesting CTPAs and investigating further for pulmonary emboli, as there is definitely a link with coagulation problem. There is a frequent co-infection with other respiratory pathogens such as flu and atypical respiratory pathogens, and in fact there is a, like I said, COVID is still only just 8 months old, this disease, but there has been some research done to show that co-infection with flu and COVID gives you a 6 times higher risk of death. So looking for other co-infection pathogens is quite important, especially if you have those true flu-like symptoms. And for that, there is a respiratory screen extended panel swab, which is a nasopharyngeal swab, and that should be done. And you can get more micro advice on that. There is on ice, if you are requesting stuff on ice, there is a bespoke COVID tab. All investigations relating to COVID are under that, just to make life easier for you. So do look at that. Okay, so they should start to build up the picture of what COVID patient looks like in your head. And then once you're suspecting COVID, or once you've proven COVID, especially COVID pneumonia in somebody who's in hospital, how do you then assess what care they need? What is the management next? And for that, we developed a combined functional assessment score of patients' baseline functional status. And that was a combination of the well-known clinical frailty score, the Rockwell score, as well as the very well-known WHO performance status. So these individually are very well-known, well-established scores, but we added them up to create a bespoke score. And that held us in good stead during the first wave. We were able to cohort patients based on that scoring to build the wraparound care that these patients needed, and whether they needed predominantly respiratory escalating care, or whether they needed more supportive management, whether they needed more palliative care management. And this really helped us and during the first wave in concentrating resources where they were needed to be, and for ensuring that the right patient is in the right place. However, of course, NICE did bring out their own guidance as well in G159, sorry, and clinicians are well within the rights to use that, and that the NICE guidance dictates the use of only a single score in the form of the clinical frailty score. But of course, the clinicians may not want to use a scoring system, and they may have an individualized assessment. And it's absolutely fine as long as the reasoning is robust and it's well documented. And of course, there are caveats that these scores are sometimes not valid for certain cohorts of patients, such as those with learning disability or cerebral palsy. So again, a lot of this should be individualized. And definitely one obvious thing is that the scoring system should not be used in isolation for making decisions regarding resuscitation or DNA CPR. That is not what they're designed to be. But what it should be is it should be prompting you to make active early decisions, documenting those treatment escalation plans, so that we know exactly what we need to do with every particular patient, and that's really important. So it's a prompt, and it's there in our COVID assessment notes, especially down in ED. There is a bespoke COVID assessment note, and on that there is a prompt always to document your combined functional assessment score, and then document treatment escalation plans and those things. So I think it's really important that we do this as early as possible we can. So these are the two scores, as I mentioned, very well known otherwise to clinicians who may have used it in other areas. The WHO performance status, for example, is very well used and well established in the use in cancer patients. And the frailty score is used in assessing frailty in other medical conditions. And adding those two gives you a CFAS score. And based on that, people who got a very low CFAS score, 1 to 3, we would expect that they would normally be for everything possible that we can do in terms of escalating their care if they need it. Patients who have scores between 4 to 6, there will be a clinical decision and discussion, but they may possibly be for everything, but they may be that they have to have treatment escalation plans in place to decide what's best for them. And usually patients with a clinical functional assessment score of greater than 6 would not normally be for escalation. These are people who would normally be quite frail, and even otherwise, COVID or no COVID, you might have thought that these patients would not be for more escalating treatments rather. So this is just a guide, as I said, but it prompts that early discussion and documentation. Based on that, we were able to cohort patients. As I said, the importance of cohorting is location and resource, so healthcare resource and wraparound care that we can provide for these patients. So cohort 1 is usually patients who would have requirements of full respiratory escalation and management. Usually their CFAS scores will be less than 6. They would be displaying respiratory symptoms and requiring oxygen therapy or be at significant risk of respiratory failure. They would usually be for full escalation for at least level 2 respiratory support, so non-invasive type treatments such as high flow nasal oxygen or CPAP. And they would definitely benefit from every medical treatment and intervention that we have developed all through first wave as well. So all the medicines that have come through all the research. So these are patients that you want to throw everything in the kitchen sink at. Okay. Cohort 2 is patients who may need a lot more supportive management. These are usually patients who would have a CFAS score of greater than 6, but may well be quite self-ambulatory and maybe self-caring in their own homes. They may still have a reasonable chance of recovery from their current episode of COVID pneumonia, but it may be appropriate to have some treatment escalation plans in place for them for ward level care. And again, these patients may go one way or the other based on their response to the treatments that we give them. And therefore the care may be supported using the Amber Care Bundle. They may still have some palliative care needs for symptom control, and that's absolutely appropriate. And they should still receive all the medical management that they can in terms of all the medicines that have been developed. And hence, if you see them down in ED, they would definitely benefit from having a hospital admission if appropriate. We then have cohort 3A, patients who need a lot more supportive management and enhanced palliative care management. These are patients as above in cohort 2, but are more non-ambulatory. They are more housebound or bedbound, or they may be care home patients who require significant nursing care within their care home settings. These usually, because of their comorbidities and frailty, may well have. Are you able to still see them? See, it says poor network connection. You still able to hear me? Just give a thumbs up if you are. They, like I said, they because of their pre-existing comorbidities and frailty may have a high likelihood of dying or have adverse outcomes through COVID, and therefore usually would be not for escalation beyond ward level care, but may still benefit from having medical treatment. They almost always will have a unified DNA CPR, maybe from the community itself, or maybe appropriate to make that individualized decision once they're in hospital. And when seen in ED, they may not benefit from hospitalization if that is able to be discussed fully with the patient and their carers, and may still benefit from, for example, antibiotics in the community or palliative oxygen, and that may be appropriate if very often on a practical front, it may be that we are able to organize all of that if depending upon the time of the day very often. So all these are pragmatic considerations to be made. These may well need anticipatory medications to help symptom control, and that should never be held off, really. Oops. Sorry. Next cohort is cohort 3B, patients for advanced palliative care management. These are patients who are fully dependent and require full nursing care, and they may be actively dying. They may be deemed to be actively dying, likely within hours. That this cohort has changed somewhat during first wave and then now the second wave. I think during first wave we were finding patients whose predominant reason for being in this cohort and for actively dying was severe COVID pneumonia. We are seeing less of that, and we are seeing people who would otherwise are actively dying through something else, through other medical problems, other medical comorbidities, and happen to have a positive COVID swab. But I think the principles remain the same. I think we need to look after the patient in a holistic way, aim not to move the patient from their current location. And if that is outside the hospital and you get referrals or you get asked to give advice on that, it may be appropriate to kind of bring that up to say that these patients should not be moved if it is recognized well that these patients are actively dying. They may have significant palliative care input and anticipatory medications. They may still require a lot of nursing care and frequently palliative oxygen. So these patients we should really be focused on symptom control, and their care may well be supported by the use of individualized plan of care for dying. So these cohorts, like I said, especially in hospital, really help us to funnel and channel resources to help the best care for the patients. And it would be quite useful for assessing clinicians to see them do the scoring, assess these needs for the patients and document them fairly early on, and that really helps patient flow teams and it helps clinicians to kind of direct the right care. Now, a little bit about medical management and advances that have happened over the last few months. I mean, antibiotics are not new, and very often there is frequent bacterial co-infection. My microbiology colleagues might chastise me for saying that, but it is sometimes hard to differentiate between viral pneumonia and bacterial co-infection on top of COVID. But there are certain features that might help us. A raging neutrophilia, sort of more solid pneumonia lobar change on chest X-ray, and purulent sputum does point more towards a bacterial infection. And the trust-wide SOP is going to be your Bible, your go-to guide for seeing what specific antibiotic therapies are appropriate and which antibiotics to prescribe for what doses and for what duration, really. So I'm not going to elaborate on that, but you need to know where the trust-wide SOP is and you need to look at it. It's there. It's been emailed to everybody, all staff as well in the past, but also is there both on the extranet under the coronavirus tab and also on the hub under policies and procedures. The absence of neutrophilia, quite significant lymphopenia and fluffy scattered ground glass change points more to a pure viral pneumonitis. But again, right at the very start of the patient's journey, it may be hard to differentiate between the two. But the one thing that I do need to say from an antibiotic stewardship perspective is that review IVs and change to oral step down as soon as you can, and send microbiological specimens as much as you can in terms of blood culture, sputum, etc. So we can sort of have the best personalized treatment, really. And some newer therapies, not newer therapies as such, but advances that have been made through research in the last 6 months, 8 months for COVID is based through clinical trials. And I'm happy to say that for once, actually, some rapid results were obtained via clinical trials. We very rarely see that in research. Recovery trial, and like I said, on a personal note, it's quite important to me because I'm the principal investigator for the trial at this site. But it is the largest clinical trial for COVID patients in the world right now, and it has got multiple arms, and those have led to quite significant research, significant outcomes and results. And even negative results. For example, very early on, the recovery trial showed that hydroxychloroquine did not work in COVID patients, and therefore should not be given. One of the other arms was a combined antiviral called lopinavir-ritonavir or Coletra, which is an antiretroviral used in HIV patients. Tested that as well, and that also showed no benefit. So it was quite important to get these negative results as well early on. But one clear positive benefit was steroids, dexamethasone, in hospitalized patients who needed oxygen therapy or some form of ventilation. So it's a 10-day course of dexamethasone, and that definitely showed benefit, both in terms of softer outcomes like improvement in symptoms and severity, but also in terms of need for ventilatory support and mortality. So that's really important, that patients fared better, up to 33% in ventilated patients and 24% in those needing oxygen. So that was a very clear win from the recovery trial. Similar trial called REMAP-CAP looked at hydrocortisone and found similar results. So that led to the UK MHRA issuing a CAS alert instructing all trusts to look at having steroids, both of these steroids, as a standard of care for COVID patients who get into hospital with either severe or critical COVID, and there are criteria that have been put out. Meanwhile, WHO also did their own interim guidance and based on a meta-analysis of all worldwide trials relating to steroids in the form of a meta-analysis called WHO REACT, and that again gave clear recommendations to give steroids for patients who are hospitalized, so are in hospital and meet the criteria for severe or critical COVID, but with clear recommendations not to use them in non-severe disease. And you can sort of understand the reasoning behind it as well. The patients who end up with quite severe or critical disease very often is due to the body's hyper exaggerated immune response, to the presence of COVID, and therefore the steroids help to suppress the immune response and help outcomes. Whereas those people who got non-severe disease, their bodies are fighting COVID themselves very well, and you wouldn't want to suppress that innate immune response by giving them steroids. So it's quite clear whom to use steroids in and whom not to. So the patients who are going home after a diagnosis of COVID or who are in the community are not the ones to be giving steroids to. This slide is, the text is slightly smaller, but I hope you can still see these have got clear guidance on what constitutes a severe COVID infection and what constitutes as critical COVID infection, and what doses of the steroids and which steroids to give for what duration. So this is there it's got its own SOP, and it's on the hub again. Corticosteroid use in COVID is on the hub and on the extranet page, but this particular snapshot page is also there on the Trustpilot SOP, so it's there for you as a ready reckoner as well. So what other aspects of medical management? Some simple practical things: avoid using fans to cool patients. Obviously, you don't want to spread the infection around. Avoid using non-invasive type therapies outside of the right setting in relevant enhanced care areas and intensive care. Quite important to continue research. As I mentioned, research has been a big win in this. So continue to highlight positive patients to the research nurses wherever they may be. We do try to cohort patients on the COVID wards, but occasionally patients will turn up as positive in other wards, and please do highlight them to research nurses for continued recruitment into the clinical trials. We have got not just a standard arm, but also convalescent plasma arm live at WHH currently from the recovery trial perspective. So that is patients receiving convalescent plasma from patients who have recovered from COVID. So that is again something that might yield good results for any potential second waves and subsequent waves. Similarly, an antiviral called remdesivir is now available to use. It is an unlicensed and high-cost drug, so there is some restrictions on its use. However, it is available for patients who are hospitalized with any sort of significant COVID pneumonia, needing oxygen, etc., and for usually those who would be for escalation. It is a consultant only and an unlicensed use and requires the blue tick access for high cost drugs. Right now, most of the usage is only on A7, A8, which are the cohorted COVID wards, and as well as intensive care. But if there are any patients elsewhere who might be able to be escalated to intensive care, then there are certain consultants within the trust who have got the access to that, and we can be contacted for that. The pharmacist would usually know that. So it has been shown to reduce severity and duration of illness, although the evidence is not as strong as for the steroids. So there's a lot of hope really in terms of medical treatments, and that has been developed over the last few months quite quickly. So there is stuff we can do about COVID pneumonia, and we need to be remaining just as vigilant and just as proactive for managing these patients. And that involves escalating. These are sort of standard escalation parameters. You would probably use the same parameters for any other pneumonia or any other set of respiratory illness that you might want to escalate up. But the main thing to say is that escalation of COVID patients specifically to ITU should go through one of our respiratory consultant gatekeepers. They are available via phone, via switchboard, in the form of the real phone, the respiratory escalation advice line. And switchboard has that number. So if you are in doubt, please do ring that number, and we can talk you through about whether it's appropriate to escalate to critical care. We do need to try and preserve critical care capacity as much as possible. So that's why we introduced this step of a gatekeeper from respiratory. And the escalation process, again, when medical teams are seeing these patients across the hospital, the important things is to know their COVID status, whether they are COVID confirmed positive or negative, and what level of dependency and what baseline clinical frailty they have. And again, that shows us what we need to do in terms of escalation. The only exception is ones who are the standard type 2 respiratory failure for things like COPD exacerbations, who are not for level 3, they may still be managed on ward A7, and that again needs to go through the respiratory consultants. We are only a small team, and we carry this Bayton phone, like I said, 7 days a week. So bear with us if you don't answer immediately, but that phone is there available for use for all staff or clinical staff via the switchboard. And just finally, there's some other sort of resources and signposting. You would have noticed changes to discharge summaries with the addition of a COVID status right at the top, and it's really important to fill those in for our primary care colleagues and GPs. They need to know if the patient's been in hospital, if they have had a positive swab, a negative or unknown. If they are care home patients, they almost invariably need a negative swab before they go back very often. So that's quite important to sort of fill the relevant field on the discharge summary that goes to the GP. There's also a patient letter. This is fully editable and printable and given to patients. So that's there on Lorenzo, and you can look it up with the percentage COVID percentage sign, and that pre-populates the patient's details onto that letter, and it has all the usual guidance that you've been tested positive, you need to self-isolate, what the family need to do, what all instructions are there with regards to managing that isolation aspect and when you're going home. We are updating that letter as we speak. There's some information that has changed from government guidance that's changed. So therefore we are editing that letter ourselves. But if you do come across a patient that you're sending home, you can yourself edit that and delete out stuff which is inappropriate. And finally, a shout out to family liaison officers as well. They were really incredibly helpful and useful to maintain communication during the first wave. They were redeployed staff. Many of those have gone back to the normal roles, so there are fewer of them around. But if you have a family liaison officer in your clinical area, in your ward, do make use of them to maintain that communication with the relatives. As again, we are in the middle of a proper second wave, and we need that communication line open with the carers who will be feeling very anxious and patients who will obviously be very anxious in hospital. So please do use them if they are there in your area. But again, it just highlights the importance of communicating daily updates to the family and the patient really. So that's me as a short, quick snapshot. And I'm happy to take any questions really.
So thanks, Mithun. That was absolutely fascinating and really so clinically relevant as we find ourselves now in the second wave. We've had a couple of questions for you. One, Dr. Atagur, who says, with severe COVID-19 with ARDS, have a very high D-dimer, irrespective of the presence of VTE, so didn't think that CTPA would help.
So I think what I would say is that if you have a D-dimer right at the start, positive, and a high D-dimer, you need to be screening for VTE. So how would you know that they don't have VTE? You need to be screening for VTE. And if you don't find VTE on CTPA, on intensive care, we have got an agreement that we clinicians are using enhanced prophylactic doses of anticoagulants for this. But this is only, again, this is off license. We don't have national guidance for this. You're not the only one who's picked this up. This is a slightly sticking point, as there is no national guidance for this, unfortunately. But there is local policy within intensive care that these patients do get enhanced thromboprophylaxis even if they don't have a VTE. But the important thing, right, is when they are on the general wards, is to screen for VTE for patients who have COVID and who have got a high D-dimer.
Thanks, Mithun. And the second question was around criteria and saying about a dry cough being one of the new criteria for COVID.
Cough has always been one of the criteria, I think, and like I said, the vast majority do have a dry cough. Sputum production is less prevalent, and in fact, having quite a lot of excessive sputum, especially purulent sputum, points more towards a bacterial infection. But dry cough has always been one of the symptoms, so I don't think it's changed from what I know on the government guidance.
Thank you. That's all the questions for this afternoon. So once again, big thanks to Mithun for being with us this afternoon. I hope you found the session really useful, and we'll see you all again next Friday for a Grand Round focusing on microbiology when we'll have one of our consultants with us and also the Director of Public Health. Thanks very much, everybody. Have a good afternoon.
Thank you. Thanks.